Now it's my pleasure to introduce Dr. Leonie Herx. Leonie is a physician trained in family medicine and palliative medicine, having completed her MD PhD program at the University of Calgary. She is the chair of the Division of Palliative Medicine in the Queen's University in Ontario. And Leonie is going to give us the current perspective on the situation in Canada. Thank you, Leonie.
Thank you very much for having me. I'm just going to pull up my slides. All right. Thank you very much for the opportunity to meet with you today and share some of our Canadian experiences with euthanasia and assisted suicide from the past 5 years since the practice has been legalized. So what is medical assistance in dying? Medical assistance in dying involves the administration of a lethal dose of drugs at a patient's request to end their life. In Canada, medical assistance in dying, also known as MAID, includes both euthanasia and assisted suicide. In euthanasia, the lethal drugs are usually injected by the doctor, and in assisted suicide, the patient takes the lethal drugs themselves. When given the option of euthanasia or assisted suicide, almost all patients have chosen to die by euthanasia in Canada. In 2020, for example, over 7,500 assisted deaths in Canada were through euthanasia and only 7 by assisted suicide. The Canadian legislation has progressed over the past 5 years. It was first legalized in 2016 for those that had a reasonably foreseeable death. Canadians believed this would be for exceptional circumstances for a very few people who had intolerable suffering at the very end of their lives. Since then, eligibility was expanded through wide interpretations of the legislation and court rulings. For example, in Ontario, a 77-year-old woman with osteoarthritis had euthanasia after a judge ruled that the reasonably foreseeable death criterion did not require any specific prognosis. In March 2021, the reasonably foreseeable death criterion was removed entirely, extending eligibility to those with chronic illness, disability, or mental illness as a comorbid condition. And starting in March 2023, euthanasia solely for mental illness will be allowed. In 2021, the government also removed a number of the safeguards that were initially put in place to minimize harm, but later became seen as barriers to accessing euthanasia, such as the 10-day reflection period. That's the time between the written request for MAID and delivery of the lethal dose of drugs. Patients with a reasonably foreseeable death can now request and receive an assisted death on the same day. Further expansion of MAID is happening through stages. A parliamentary committee is exploring euthanasia for youth deemed capable of making their own medical decisions, known as mature minors, and through advanced directives. We are now seeing MAID requests for children, such as a mother's recent request for euthanasia of her disabled child, whom she feels has a poor quality of life. Her request is being championed by our parliamentarians. Eligibility for euthanasia in Canada under the current legislation now includes any manner of chronic illness, such as chronic lung disease, chronic kidney disease, heart disease, diabetes, chronic pain, arthritis, and neurological conditions such as epilepsy. It includes disability with a very broad definition to include any permanent, temporary, or episodic disability, anything that hinders a person's full and equal participation in society. This would include deafness, visual impairment, or dyslexia. Mental illness alone, as we've said, will be allowed in 16 months' time. The number of MAID deaths in Canada has increased exponentially. Up to the end of 2020, there's been over 21,000 MAID deaths, with an exponential increase each year between 20 to 35%. We don't have the 2021 statistics, but we do know that in some provinces, including Ontario and Nova Scotia, they had already reached their 2020 numbers by the end of August 2021. Overall, there's been a 650% increase in the number of deaths through euthanasia in the past 5 years. There's also regional variation, much like Professor Boer described in the Netherlands. We see on average 2.5% of all deaths are through euthanasia, but in some areas, there are higher and lower numbers. So in Quebec, it's about a 3.1% of all deaths, and in British Columbia, over 4% of all deaths. The reasons for requesting euthanasia and assisted suicide in Canada are consistent with those of other international jurisdictions. Canada's data shows that requests are due to psychological and emotional distress around the fear of dying, including the fear of being a burden to others, loss of ability to enjoy life, and desire for control. It is not due to uncontrolled physical symptoms such as pain, contrary to portrayals in the media and by euthanasia and assisted suicide lobby groups. At the outset of the Canadian assisted death regime, we were told and reassured that a carefully designed and monitored system of safeguards would limit harm and any risk of wrongful death to vulnerable persons. However, every year there have been documented cases of non-compliance with safeguards and misapplication of both law and policy from MAID. The Chief Coroner of Ontario, the End of Life Care Commission in Quebec, the British Columbia Coroner's Service, and the Correctional Investigator of Canada have all reported on these issues. We also have reports of disabled Canadians being pressured by healthcare workers to consider euthanasia because of ableist attitudes about their perceived quality of life or high costs of care. For example, Roger Foley, one slide ahead, a 42-year-old man living with a chronic neurologic condition in London, Ontario, who recorded a hospital administrator suggesting he should get MAID because of the cost for his care. Let's go back to this one. We also see reports of Canadians seeking euthanasia through loneliness and depression from social deprivation or inability to access the care and support they need for living due to high costs of care, poor conditions at care homes, fear of loneliness and COVID lockdowns, and prisoners who are refused parole. We know that many requests for euthanasia are due to people feeling that they are a burden to others. This sense of being a burden and loss of dignity is amplified when resources to help people live do not exist. Disability rights groups have condemned the expanded Canadian legislation as making disabled people feel less valued in society by giving them a fast track to assisted suicide rather than suicide prevention and assistance in living. The Canadian Federal Minister for Disability Inclusion recently stated that in some places in our country, it's easier to access MAID than it is to get a wheelchair. Despite her statement, she still voted in favor of the expanded MAID legislation. The impacts on medicine have been profound. Euthanasia in Canada has been radically normalized as routine medical care and often confused with the stopping of medical treatments that are no longer of benefit or the use of medications to optimize symptoms when providing palliative care, neither of which are euthanasia. The use of euphemistic language, medical assistance in dying, has perpetuated much of this confusion. MAID is presented as just another tool in the end-of-life care basket, but euthanasia is not end-of-life care. It is intentional ending of life. This is a seismic shift for physicians. We know that a desire to die often comes from grief, anger, loss, and despair as people adjust to a devastating diagnosis or a change in their condition. This lament is often a cry for help. Unfortunately, it now results in an assessment for euthanasia, often before palliative care or psychosocial supports have been involved. Some doctors in Canada are now facilitating suicide completion rather than suicide prevention. For example, an actively suicidal patient seen in an oncology clinic with all of the red flags for high risk for suicide completion, previous suicide attempts, prior history of depression, a clear plan, and access to a weapon. When psychiatry was consulted, rather than admitting the patient, they gave the patient the number for the euthanasia team. Some physician regulatory bodies and associations are suggesting that euthanasia should be raised to patients alongside all other therapeutic options. But euthanasia is not just like any other option. It is irreversible. If a doctor offers unsolicited euthanasia as an option to a patient, this can easily persuade a patient to pursue it. Patients take doctors' recommendations seriously due to the trust in their expertise and knowing that they have their best interests in mind. All healthcare facilities in Canada are expected to provide euthanasia regardless of their philosophy or focus of care. Hospices whose core philosophy includes not hastening death cannot opt out. For example, the Irene Thomas Hospice was shut down for refusing to provide MAID on site, even though patients could access the procedure next door at the hospital. There are no euthanasia-free safe places in Canada. Under Canada's legislation, there's no requirement for the patient seeking MAID to have tried any evidence-based therapies or to have supports in place that could alleviate their suffering that's underlying their MAID request. They only need to be informed of their options, even in the case of potentially treatable conditions. But being told about something and experiencing its benefits are very different. This allows death to be administered as a first-line treatment and has significant implications for a doctor's ability to practice medicine according to their conscience. Conscience is not about religion. It is about being able to practice medicine with professional and moral integrity, providing recommendations within the scope of their specialty, in the patient's best interest, and within the medical standard of care. What if a doctor knows that there is a treatment that can address the cause of a patient's suffering and it has not even been tried, yet the doctor is required to facilitate ending a patient's life because that's their choice? Many physicians will not be able to participate in this in good conscience. There are no robust legislative protections of conscience rights for doctors, pharmacists, nurses, and other healthcare professionals from having some involvement in assisted death once it's legalized, even when they professionally feel it is not indicated or necessary. Participation in euthanasia is forced in some jurisdictions in Canada through institutional policies and regulations, or face disciplinary action such as a loss of hospital privileging or a loss of medical license. With MAID eligibility now expanded to include chronic illness and disability, many more doctors are calling for better conscience protection, as almost every medical specialty is now impacted by MAID. Euthanasia has been romanticized as the most beautiful death and marketed as the only way to die with dignity. This has perpetuated myths and increased fear about natural death and dying, which is most often peaceful and comfortable. Specialist palliative care provides expert care and comfort for those with more complex symptoms and should be made readily available as an essential service. Those of us who voice concerns about patient safety or are advocating for the necessary safeguards to prevent wrongful deaths have been dismissed as being anti-MAID or accused of trying to block access to MAID. There is also bullying and marginalization within medicine and within institutions for those not seen as championing euthanasia. This is causing significant division and conflict within the medical profession. In my experience, there is not a day that goes by now that doctors are not facing an ethical dilemma or moral distress related to euthanasia. It is exhausting and demoralizing. Many colleagues have stopped practicing palliative medicine because of this. I keep going by knowing that those patients who do not want euthanasia will not have other options for care if we all leave. This quote from Canadian bioethicist and physician Dr. Nuala Kenny sums up the Canadian situation. Legalizing euthanasia fundamentally changes medicine, the role of the doctor, and society itself. Once brought into medicine, there are no rules or safeguards that can be put in place that will keep euthanasia restricted to a very few with extenuating circumstances, as is portrayed by its proponents. Don't be deceived. Administering death is cheaper and easier than providing care, and it will quickly become the solution for any form of human suffering, as we are now seeing in Canada. Thank you.
Leonie, thank you very much for that. A very interesting perspective and some parallels, I think, with the situation in the Netherlands. So I've got questions for both of you from our audience, and if there's time, I might interject one or two of my own. But let me start, Leonie, if I may, with you, if you don't mind. So you demonstrated, parallel to the Dutch experience, a fairly dramatic increase in numbers in Canada, again with regional variation. And perhaps we'll come back to that issue. But my question, or my group of questions here, concern the impact on those who are involved in the process. So first of all, what about the impact on doctors who've been involved in euthanasia? And is there evidence to support any concerns that we might have about the impact on the medical staff involved in this?
Yeah, so there's more evidence from countries who have been doing this longer than Canada. I don't think we have good studies yet in Canada that are looking at made professional demoralization and moral distress, but from the Netherlands and the Belgium studies, we do know that there is even those who are in favor of euthanasia and provide it do experience a degree of moral distress and moral injury. And some people have stopped providing that used to provide before. I don't know that we have all the evidence that we need to better understand what it is that they're experiencing, but definitely some complex moral distress.
And I guess, like many people on our session this evening, some of us have been somewhat alarmed at the evidence of state compulsion in some areas of Europe right now. And so, Leonie, again, just to stay with you for a moment, is there an opt-out for doctors and nurses in Canada? And have you ever yourself been forced or been put in a difficult position about this issue, being requested to administer?
Yeah, so the legislation doesn't require anyone to give the lethal injection yourself, but there's no protection from you being forced to facilitate and participate in it in some way. For example, by finding a provider who will do it for the patient, if you're not willing to do it yourself, for helping with the paperwork, things that would be, for some people would be against their professional integrity, that this is in the best interest of the patient, especially when in Canada you have it for reasons that people are lonely and isolated and they haven't tried treatments that can alleviate their suffering. As I said, it can become a first line option in that sense. So for many physicians, it would be, even if they're in favor of euthanasia, it would often be the case that this is not something they feel they can participate in. And so there's no protection from that piece. There's it's the actual act of doing it itself. No one is forced to do the injection, but there are many different types of participation that cause moral distress and cause people to go against their conscience. Yeah.
Okay. Let me turn, Miro, if I may, to you. You spoke very convincingly about what appears to be evidence of increasing acceptance, perhaps relaxation of the indications that there are. Maybe in the Dutch experience, I know there's been some concern about the laxity in recording and registration. You talked about cost. What do you think are the principal concerns, the major factors relating to this kind of what you might call mission creep, I suppose?
Well, I think it relates back to the points I made surrounding the inconsistencies in campaigns and narratives surrounding those who are pro this legislation. So often we have seen different impairment groups argue and articulate, based on their personal experiences, why there should be justification. So typically what you have found in every situation where there has been assisted suicide legislation, the continued pressure to offer a way in for more and more groups. And I think that this shouldn't be a surprise because it reflects the narratives that have been around for many years about why there should be justification for this. But it also ignores the systemic and grave violations that are affecting disabled people and people with health conditions. And we can't lose sight of that. So when you have the United Nations Committee on the Rights of Persons with Disabilities in their thematic report, I think within around 2020, highlighting the impact of ableism in medical and scientific practice and links very deep concerns about assisted suicide and euthanasia and so on. You have a situation where there is widespread condemnation, but there is also this continued pressure by campaigners. And the legislative creep will occur if you don't have a situation where the alternative is, as I articulated, a situation where the language is so vague surrounding eligibility that the pressure to include more categories as defined as terminal ill becomes a realization. So, for example, I think about my own condition. one where you could argue that my life, my death will be driven by my impairment of a neuromuscular condition that causes severe muscle weakness and respiratory failure and decrease. But alternatively, and my position as a sociologist would be, I think that my death will likely occur because of an arrangement of different issues that includes a lack of support, the constant fights and battles I have to have in order to access healthcare and technologies, and the constant pressure that I have to resist when I engage with medical professionals in a crisis where they have questions about, should we place do not resuscitate notices? Should we discuss options for what may happen if we need to think about withdrawing support and so on? So these situations are very vivid. And as I said right at the beginning, we shouldn't be driven by the personal stories, whilst they are very important.
Yeah.
We need to think about the collective impact of policy and legislation.
Yes. Yes, Mary, just before I go back to Leonie, you mentioned concerns about safeguards. Do you think, as you've analysed this whole position clearly in some detail, do you think there's a workable solution that would satisfy those concerns?
Well, I've been involved in these debates for many years, in particularly again in regard to Westminster government as well. I cannot think of any situation where any of the safeguards will be to an extent that will address the concerns raised by people. And the point that we often find ourselves in is that those who are highlighting concerns are dismissed. Issues of scaremongering, issues of articulating very wild accusations and so on. But if those who are supporting this bill believe that it works, then they should be able to systematically address all the concerns outlined by the three of us tonight in our presentations and in other campaigning groups. But they don't, because often the situation, the outcome is just to dismiss the concerns. So as I said in my presentation, I don't think the safeguards work, particularly because, as you've seen in Oregon and other places around the world, you have a situation where if there is disagreement, people can go and seek another alternative opinion from somebody else. And when there are questions about assessing capacity and decision-making and so on, they are relying on mechanisms that are so vague that they are meaningless.
Yeah, thank you. Leonie, do you have information about how many MAID requests are actually declined?
So there is some reporting on that by the Government of Canada, but again, like the monitoring and reporting of MAID is left up to the subjective will of the MAID provider. So there's no kind of oversight mechanism. So we only know what MAID providers choose to tell us, and they submit their reports. So I don't know that that data is accurate in a sense of how many of MAID providers would submit a report online, which is, it's a lot of hassle to say this person requested MAID and I didn't approve them. So I don't think that we have accurate data in that regard. Anecdotally, it's not common that someone who requests MAID doesn't get it, but the numbers aren't very reliable.
Yeah, thank you. Certainly there does appear to be, from my reading of the literature too, a sense in which an element of laxity kind of creeps in, and familiarity perhaps with the process, and so maybe that leads to human cutting of corners or whatever. Here's a question for you. Now this is to someone who clearly has experience, Leonie, of a situation where you have both euthanasia and assisted suicide available. Now clearly, with some of the information that Theo passed on and the material that you referred to, this questioner asks, do you think it would be a better option to only offer euthanasia and forget about assisted suicide, which appears to be the kind of purpose that's out for consultation in the proposed Scottish legislation? What do you think?
So I think that it goes back to the safeguard question that you just asked, Miro. I think that neither option can have safeguards that are enacted that would prevent someone from having death wrongfully done to them because they didn't have access to the care they needed, or because there was pressure or coercion that wasn't detected. So I think regardless of whether it's euthanasia or assisted suicide, the issue is around, can it be done safely to prevent harm to vulnerable people? And I think the answer, based on the Canadian experience and on the Dutch experience, and I would say on the Belgian experience, is no, that there are no safeguards that can be put in place that have stringent enough rules and oversight that can detect things like subtle pressure, and it is left to the subjective interpretation of what a person feels their suffering is and whether that particular MAID provider agrees. And as Miro has said, there's a smaller group and a smaller and smaller group over time of people who provide MAID, and we do see doctor shopping. You're allowed to go to as many doctors as it takes to get to assessors who agree that you can get MAID. And so there's a lot of problems with safeguards and oversight.
Yeah. Now, you're a palliative care physician, yeah? So what about those who would say, well, yeah, we see the importance of having enhanced palliative care. We ought to invest in palliative care. But why don't we retain assisted suicide or euthanasia, for that matter, as an option as well? So we have a menu of options and we can tailor it to the particular needs of the patient.
Yeah, I think I would refer back to something Professor Boris said. There's never been a time more in history where we need it less. We have come so far in palliative medicine and being able to take care of pain and other symptoms. But so from a just a physical necessity, there's no need for anything other than really good palliative care. But those aren't the reasons people request euthanasia, right? And so it is all of this other stuff that Mira was getting at, that the value and the dignity of the human life and how we support people in dignity in living. That is a real cultural issue that needs to be addressed, sorry.
Yeah. Here's a question just come in actually, which asks, so what do you think about the fact that public opinion appears to consistently show public support for assisted suicide? Should we ignore the majority view? What do you think about that? Perhaps Mira will turn to you for an answer to that one. So the wave, the sort of tide of public opinion seems to be running in a particular direction. Can we stand in the face of that with logical argument? I mean, you've certainly given us some logical arguments tonight, but what about the weight of majority opinion, or what appears to be the majority opinion?
Well, my first response is always to question how existing data that gauges public opinion is supposed to represent a considerable number of people. So, for example, in the consultation for the bill, I see the reference made to various data sources, and of course, when you drill down into those numbers, you're talking about a survey responses of 1,000 people or so, and that is supposed to reflect then disabled people who, from the latest figures, and these will be conservative, constitutes 1 million disabled people in Scotland. So I don't know how you can generalize findings to that level. There's also, I think, a problem and a concern here. So, for example, I remember reading some arguments that suggested disabled people's organizations are supporting of this. And there has been a reluctance by certain disabled people's organizations to state a position on this. But we should remember that reluctance doesn't imply neutrality. And so I think there's something here about how we have to acknowledge the broader patterns of injustice and social inequality that are facing disabled people. So we have disabled people who are experiencing hate speech, hate crime, lack of support, questions around why do disabled people exist. These will be reflected in the bill. So whilst you may have certain levels of data that suggest that some people may be supportive of this, my argument to politicians and policymakers is that whilst it is indeed important to be made aware of social issues and problems, your role and your responsibility is to critique and assess this beyond the personal opinion and to be rooted in the evidence and the data that surrounds the social topics that we're talking about. And if the evidence and the data based on today and based on the broader systematic literature reviews that one can do is highlighting all these concerns, then I say that we need to be cautious about being led by public opinion.
Yeah.
We have a responsibility to think about the broader implications of the decisions that we make through legislation and policy that will have a substantial impact and legacy within society. And that's why I would always employ any policymaker, and I've spent many years as a policy advisor to governments across Europe. I would always say that your first instance is not to react immediately and support the public opinion. It's to take a hold of their concerns and then to make judgments based on evidence and based on literature.
Yeah, I think
if I may
Leonie,
jump in, yeah, sorry if that's okay. Not that I can add anything to that brilliant summary, Miro, thank you. But just to say that I don't think that the public really understands in general what we're talking about. And I mentioned in my remarks that many people think that stopping life-sustaining treatments or burden, things that have become no longer a benefit to a person is assisted dying or is euthanasia. They also think what we do in palliative care is euthanasia. And I still, even 5 years into legalization in Canada, every week in my work, I encounter a patient or a family who thinks that euthanasia or assisted dying is something else like those two things I'm talking about. So I think there's even some recent polls in the UK that show that the public thinks that's what we're talking about when we say assisted dying. So do they actually understand that we're talking about a lethal injection or a lethal dose of drug to immediately end someone's life? I'm not sure. Yeah.
Okay, so there were a couple of questions earlier on about the actual medications that are being used. And of course, there's no, as I understand it, no uniformity around many different jurisdictions where this is active in some form. But let's just focus, if I may, maybe come to you, Leonie, and look at the assisted suicide issue. What are your thoughts about the medications in terms of their effectiveness? Is this something which uniformly produces a trouble-free, dignified death? What about clinical studies on the different options that might be available? Is there any kind of strong message appearing in relation to the actual techniques and or agents being used?
Yeah, so I will disclose I'm not an expert in this area. It's not something I choose to practice in. I am familiar with the literature. And I think that is the reason that's led to most jurisdictions now offering the euthanasia backup option, including, we're seeing that in California, coming in California, as well as in Washington, where there are a number of incomplete assisted suicides, and that then they want to provide euthanasia to complete the act, so to speak. So there are difficulties with self-administration, and it can be, the reports of it being a very prolonged, protracted death, and so not necessarily as comfortable as it's made to seem, which is why I think we have a higher number when given the option. Euthanasia becomes the easy option for patients because it's medicalized, it's a doctor who does it, it's kind of very clean and reliable. And so I think it also, one has to wonder, and we don't have time to get into this, if it's easier to have something done to you than to do it to yourself, which is a philosophical question.
Well, listen, we promised our audience that we would be finished by 8 p.m. and I'm determined as chairman not to lose my reputation, so to deliver that end. Someone has just made the comment, however, that just in relation to the public opinion issue, so often these questionnaires or opinion polls are rather unsophisticated, and when people then are presented with a rather more nuanced or realistic set of arguments and reality, the opinion polls don't necessarily show informed public opinion at all. But I think we need to end it there. It's 1 minute to 8. So let me just say to everyone who's involved how stimulating this has been. It's been a really good session. I'm grateful to our speakers today, to Theo, to Leonie and to Miro. And on your behalf, I'd like to thank each of them sincerely for the effort and energy they've invested in highlighting the various issues that came through. And thank you to all the delegates, for those of you who connected in and who asked questions. I apologize if we didn't get to every question. Time was not really on our side there. But I can tell you that it might well be worth your while visiting the carenotKilling.scot website. There you can register for their newsletter. You'll be notified when the next Holyrood webinar will be taking place. And so with that, let me just offer my thanks, wish you all a very good evening, and to say that this concludes today's webinar. So thank you all very much indeed.